Yeah, so hi everybody, my name's Kate. I am your clinical specialist with Baxter, so just come and do all your CRRT stuff on your machine. I'm also a PICU nurse by background, used to work at Nottingham QMC and helped them write the citrate protocol there. So that is good news for you guys, because that's the protocol I think that you're basing your protocol on, so I'll be able to give you lots of support from that point of view. So from a little citrate update, I've got a little slideshow which I'll quickly just go through in a minute that just gives you the basics of citrate and how to monitor it and stuff on the unit. You guys have had, for the unit, all the nurses have had training a couple of weeks ago now, so you're pretty much up and ready to go. So as soon as you have a patient that requires filtration, then you can use your new Prismax machines and use citrate anticoagulation instead of heparin and see how you get on. So effectively, yeah, we're just waiting for a patient that needs filtering, so we'll see how we get on. But yeah, I'm just going to do a quick slideshow that just, it's not very long, it's only a few slides that just tell you a bit of basics about citrate, how it works on our machine and how to monitor it. And then if anybody's got any questions or stuff afterwards, then we can answer those. Right, let me see if I can share my screen. I've not been on Zoom for a little while. Can everybody see that, the screen?
Yeah, perfect.
Yeah,
thank
perfect.
you.
Right. So yeah, so citrate anticoagulation, we're gonna.
Yeah, perfect, beautiful, thank you.
Can you see? Perfect. So yeah, we're going to talk a bit about citrate anticoagulation. My slides will move forward. So as we all know, filter clotting is a very common complication on our CRRT filters, and it can reduce our filter efficiency because we have lots of treatment interruptions. Therefore, your patient doesn't actually get their delivered dose. So what we're trying to aim to do with our anticoagulation is try and preserve the life of our filter so our patient gets an adequate treatment on our filter. So for years and years and years and years and years, we've all been using heparin, which kind of works. Everybody's used to it. It's nice and easy, not that very cheap, but actually it can cause some issues with our patient because, as we know, the heparin goes into the circuit, but some of that ultimately will go back to our patient, so can cause increased risk of bleeding in our patient. And actually, sometimes our filters don't last particularly long with the heparin, they still clot off quite a lot as well. So in adult land, we've been using citrate in their filters for probably in the last 10 years or so. Most adult units have moved over to citrate. I will say, with the exception at the moment of the adult unit at Addenbrooke's, who I am working on. So I'm hoping that when you guys move over, we can also convince them to move over to citrate, but they're just being a little bit resistant to change at the moment, but hopefully we'll get them that way. So yeah, so most units in the UK will currently use citrate for their anticoagulation, and lots of the PRs use it on the move that way as well. So regional citrate anticoagulation, why are we going to use that? And we've done lots of research and stuff over the last few years. So it is actually now like the gold standard for anticoagulation. So the KDIGO guidelines, so the Kidney Disease Improving Global Outcomes organization, they recommend that if you're going to do CRRT and your patient doesn't have any contraindications, then you should be using regional citrate anticoagulation rather than heparin, which is why hopefully we're going to move you guys over to that. So how does it work? So citrate basically comes along and binds with the ionized calcium in your patient's blood. So the blood that's going through the filter has a really low level of ionized calcium in it, which, as you can see from your clotting cascade, you need calcium and quite a few different aspects of that for your blood to actually clot. So if you don't have enough calcium in your blood, it's physically just not going to clot. And that is literally the whole theory behind citrate. It's not particularly complicated. We just add citrate into our filter in our pre-dilution fluid. So that is just now a bag of citrate, and we'll go through the bags and stuff in a minute, but that's just a bag of citrate, mixes with your patient's blood as soon as it comes out of them, and then the whole way around your circuit for your filter, you've got a low level of ionized calcium, so your blood just doesn't clot through the filter. What then happens, hang on, we'll get to that bit in a minute. So what we're aiming to achieve inside our filter is we're aiming to achieve a target ionized calcium of 0.25 to 0.4. I think your prescription currently says 0.25 to 0.35 millimoles. So it is quite a narrow little window to hit, but if you hit that window, it means that your blood will not clot inside your circuit. And then to achieve this, you need a citrate dose of 2.5 to 5 millimoles. Most adult units start their prescription at 3 millimoles per litre of blood of their citrate. You guys are currently going to do 4 just because you're following the Nottingham protocol. They started at 3 millimoles, but then found most of their patients ended up on more than that anyway, so around 4.5. So actually they decided just to start it at 4, and it just meant you didn't have quite so much fiddling and stuff to do for the first few hours, because they kind of hit that target a lot quicker than starting at 3 millimoles and then working your way up. And due to how we monitor it, if that's a bit too much, you can just turn it down anyway. We'll talk about that in a minute. So this is your normal distribution of your total calcium in your blood. So you've got your total calcium, you've got a bit attached to your protein bound, you've got a little smidgen of that, which is complex bound, and then about half of that is your ionized calcium, which your body can actually use for all its important functions. What we're aiming to do inside our circuit is we're aiming to just move that distribution around a little bit so that actually most of that calcium is now attached to your citrate. So you've only got a tiny little bit of ionized calcium so that your clotting cascade isn't going to work properly. So that's what we're aiming for in our filter. And we'll talk a bit about the accumulation in a minute, but what we're then aiming for when it goes back to our patient is obviously we're then aiming for that normal distribution, not the one that's currently in our filter. So your citrate is metabolized into bicarb, so it will go through your liver, skeletal muscles, kidneys if they're working. Releases the calcium that it's held onto, and then it turns into 1 millimole of citrate turns into 3 millimoles of bicarb. So that's why we do say if you're on citrate, you need to keep a closer eye on a patient's metabolic status, because they could get alkalotic or acidotic depending on what they're doing with the citrate. One of our fluid bags now, and you'll see it in the next couple of pages, has got less bicarb in it than the traditional fluid bags that we use, just to counterbalance the fact that we know our patient's going to get a bit more bicarb from your citrate. However, quite a few patients that we put on the filter are actually quite acidotic, so that little bit of bicarb is sometimes quite helpful. So yeah, the blood goes back from the circuit into your patient, gets metabolized and gets turned into bicarb and releases a bit of calcium. However, your calcium and citrate molecule is really small, so most of that molecule is then lost through your filter into your effluent bag, which is great for the citrate, because what we want to do is remove as much citrate from that filter as possible, because it's done its job. We don't want it going back to your patient. However, because we're removing most of it from the filter, it will also remove all the calcium that it's holding onto. So it's really, really important that we then replace that calcium. So on the front of the machine now, where your heparin used to be, there will now be a syringe of calcium gluconate, and this will replace the calcium that we've lost through our filter. The machine does all of the calculations for you, so all we need to do is tell our machine that we want it to replace, and normally to start with 100% of the calcium that's lost in the filter. The machine will work out, based on your patient's weight, flow rates and hematocrit, how much calcium is getting lost. And if you pop in your machine, you want to replace 100%, the machine will work out the flow rate for you going back into your patient. If you change any flow rate, anything at all on the machine, it will automatically adjust the calcium for you. So it is really clever. You don't have to do any maths. So this is just a little diagram that just shows you what's going on here. So like we just said, your ionized calcium, even though the syringe is on the front of your Prismax, it doesn't actually go anywhere near your filter, because what we're trying to do is remove the calcium from our filter. So we don't want to then infuse calcium into our filter. So that calcium needs to go on a dedicated calcium infusion line directly to your patient. So ideally on a separate central line if your patient's got enough central access. If not, it can go on the return line on the vascath from your filter, but not anywhere near your actual filter. So your blood comes out of your patient. The first bag of fluid it's going to hit is that pre-dilution fluid, so your pre-blood pump, and that's got the bag of citrate in it. Just some citrate and some sodium chloride in that bag. So the minute the blood comes out of your patient, it is anticoagulated the whole way around your filter. Goes up the bottom of your filter there. Really important that for our dialysate bag, we use a calcium-free dialysate solution. And again, we'll come to that in a minute. And again, that's just because we're trying to lower the amount of calcium inside our circuit. If we then added some calcium in our dialysate bag, it's going to reactivate that clotting cascade and your filter is going to clot. So calcium-free dialysate solution. Then blood is going back to your patient, where we have got a net loss of our calcium citrate. So like we've just said, we need to replace that calcium. We then use the blue post-filter port to monitor for your ionized calcium inside your circuit, which we will then talk about in a minute. So these are the fluids. So one of the main differences, apart from the flow rates and stuff as well, but all the fluid bags on the bottom of your machine are now different to what they were before. So before, with your heparin patient, you were using Prismasol 4 or Hemosol BO, depending on your patient's potassium. So now you've got a few different bags. So like we've said, that first bag, the one on your pre-dilution, your pre-blood pump, is your bag of citrate. And that's Prisma citrate 18.0. So it's got 80 millimoles of citrate per litre in there. And like we said, not much else apart from some sodium and some chloride. That goes on your first scale. Your middle scale, so your dialysate bag, and we do most units will run citrate with CVVH DF, because what we're trying to do with that dialysate is we're trying to remove some of that citrate from our patient. So you don't have to kind of go between whether you want to do CVVH for your patient or CVVH DF. Most units will just do CVVH DF as standard with citrate. So you always have this dialysate bag going. That's Prisma 0 cal or Prisma 0 cal, so no calcium in it, and B22, so that's for how much bicarb is in it. So the upper bags have got 30 millimoles of bicarb in it. Your middle dialysate bag has only got 22, so a little bit less in there, and everything else is pretty much the same. Has got 4 millimoles of potassium in it, so we don't have any potassium-free solutions now with our citrate, and I think most units are trying to move away from potassium-free solutions and just have these ones with 4 millimoles of potassium in them. So that's your dialysate bag, your Prisma 0 cal B22. And then your replacement fluid is Foxilium. This is pretty much identical to your Prismasol 4, apart from it's got some phosphate added to it already. So phosphate, for some reason, it's quite a small molecule and it just loves to be filtered out of your patient. And we sometimes find we have to give quite a lot of phosphate corrections back to our patients. They are quite time consuming. You have to give them over a long period of time, and you have to give them over a central line and that kind of thing. So what we're trying to do here is have a little bit of phosphate in our replacement fluid. So the one that's going directly back to our patient. This will maintain, hopefully, your patient's phosphate level, so you won't have to give quite so many corrections. Again, it's got 4 millimoles of potassium in it. So pretty much standard. Use your Prismasol 4, just has a bit of phosphate added to it already. These have all gone through your pharmacy, you know what it's called, your pharmacy meetings and stuff that you've got to go through. So Nigel's got them all sorted and they're all ready to go. We're just waiting for a patient to put them on. But yeah, these are your 3 standard bags at the moment for your citrate. Also worth noting that these bags have got slightly more magnesium in them than your previous bags, and that's because citrate binds to doubly charged molecules, which calcium is, but magnesium is also a doubly charged molecule as well. So it binds a lot more to your citrate, but you might find that after a day or so, if the patient's been on the filter, their magnesium just slowly starts to drop as well, because the citrate is starting to kind of bind to some of your magnesium. So these bags have just got a little bit more magnesium in it, but it is really important that we do daily checks of our patient's magnesium along with all the other stuff when they're on the filter. And actually that's what we come to now. So same standard as heparin before you put your patient on, then really important to do a gas and check all of their electrolytes. What's also really important to do is check your patient's ionized calcium before they go on the filter. If your patient's ionized calcium is quite low when you first go on the filter doesn't really do a very good job of correcting that. What it will do, the calcium gluconate that you've got going through your machine, like we've mentioned earlier, will replace the calcium that's lost in the filter. Is not very good at replacing your patient's calcium if it was low. So you'll find that you put them on, your the nursing team will do some observations, they're choosing blood gases, your ionized calcium will be quite low. The prescription will tell them to go up on your calcium replacement, and you'll go up and up, and it doesn't make a lot of difference. So really important, if you can, obviously if it's you've got to get your patient on the filter ASAP, then pop them on the filter, but then just give them a calcium correction then. It just helps the filter run a bit nicely if they've got a normal calcium when you first go on. Once they're on the filter, within 1 hour after going on, we then take a ionized calcium from our filter, so that blue post-filter port, put it through the gas machine, and we are aiming for a really nice low level of calcium there, so 0.25 to 0.35. At the same time, we also want to take a gas from our patient and just check that their calcium is within normal limits. We then adjust that according to the algorithm which you guys have got in your prescription, which I can show you in a minute. And then once a steady state is reached, you don't then have to check it again for another 4 to 8 hours, depending on your protocol. Most units will do it every 4 to 6 hours just to check that it's still within the normal limit. So that's just your general maintenance of the machine. So just checking that the ionized calcium is low inside your machine and normal inside your patient. What we also need to check, and we need to do this every 12 to 24 hours, and I think your prescription might say a bit more often now, is we need to check that our patient is actually metabolizing their citrate. Most patients metabolize it absolutely fine. And there was a couple of slides in a minute that talk about like your liver patients and stuff. What we need to do is most units will do it 6 hours after you put your patient on the filter, send a total calcium to the lab, get your total calcium. And actually, I think there might be another slide in a minute, so I'll tell you about that. And we've talked about our magnesium phosphate, all the kind of usual stuff that we're checking when our patient is on the filter. So if your citrate is not cleared effectively, then we can accumulate it. And that's if it's not cleared by either your patient or by the dialysis on your machine, then some of this calcium citrate complex will remain inside your patient. It's not the citrate in itself that it's toxic, it's more the symptoms. And some of these can include all of the following. So any kind of metabolic derangement, really. So metabolic alkalosis or acidosis, depending on what your patient's doing with the citrate. Don't worry too much about the hyponatremia. That's because the citrate solutions that we use are a low concentration of citrates. They've only got 80 millimoles. There are some other citrate concentrations on the market, and they are a lot higher concentrations. So we don't tend to see any issues with high sodium. The hypo and the hypercalcemia is fairly obvious because we're having a little fiddle with the patient's calcium, but actually because we're monitoring it so closely, you pick up on that before it has any significant drop. And then we've talked about, magnesium as well. So it's just keeping a really close eye on your patient's gases and their electrolytes. So some of our patients that can't metabolize our citrate, these are the ones that tend to have a few more issues. And that's mainly, like we've just said, your severe liver failure, anybody with reduced blood flow to the liver. Obviously, the blood's not going through the liver, then it's not going to be able to be metabolized. And also patients that are severely shocked. So patients that have got a really high lactate for whatever reason, they do sometimes struggle with their citrate. So if you've got a patient on the filter that is quite poorly and their lactate is quite high, I would closely monitor if they were metabolizing their citrate or not. Probably actually sometimes more at the moment than your liver patients. So your citrate does like a bit of oxygen to metabolize itself. So if your patient's got a high lactate and they're in anaerobic respiration, they do sometimes struggle with their citrate. The inadvertent overdose tends to be more those patients that may be on the filter, but they're also receiving lots and lots of blood products as well, because the blood products that you get from the lab have got citrate in them to stop them clotting. So if you've got a patient having citrate through the filter and lots of blood products as well, they might be just having lots of extra citrate that they might struggle to metabolize. However, there's actually lots of evidence nowadays that suggests the liver function isn't actually that big a deal as it used to be. It used to be a big contraindication for patients on citrate, but most liver units now, King's big adult unit, they use citrate as their first line anticoagulation. These patients you will just need to monitor a lot more closely, and it may be that they just need a slightly less amount of citrate than some of your other patients. But actually, most patients that have got some impaired liver function do cope okay on the filter. So like we've just said, actually, the frequency of their metabolic issues is not actually that big an issue anymore. But yeah, so your liver patients and those patients with a really high lactate. And actually what we say for most of our patients, if your patient is not metabolizing their citrate, then that's probably the least of their concerns on PRCU, to be fair. They're probably those really, really, really poorly ones where any kind of anticoagulation is going to give them issues, probably, and they're not going to do particularly well with heparin either, really. So how we keep an eye on that is this total to calcium ionized ratio that I was just talking about. So you need to get your total calcium and you need to send that to your lab, because what will happen is I'm trying to see this picture in a minute. So you grab your total calcium, not too far. There you go. So when your patient first goes on, I think your prescription will say at a 6 hour point when they've gone on, send a total calcium to your lab. And what you need to get from the lab is a total calcium, not the adjusted or the ionized calcium, or your adjusted, or what's the word for it? The one that, anyway, to get your total calcium from the lab. at the time that the nurse took that from your patient, they would have written down what your patient's ionized calcium was at the time they took the bloods, because the bloods will go to the lab. They won't probably come back for a few hours, depending on how busy they are. So get your total calcium at the time the bloods were taken, write down the ionized calcium of your patient, send the bloods to the lab. When you get your total calcium back, you then need to divide that by what your patient's ionized calcium was at that time. That ratio should be less than 2.5. If it's less than 2.5, effectively means your patient is metabolizing their citrate and we're happy, absolutely fine. If your patient's ratio is more than 2.5, then it suggests that actually your patient is not metabolizing their citrate, so it's swimming around in your patient's body, holding on to a lot of your calcium. So if you think back to that little graph that we showed you earlier, this is an example of your normal, what a normal ratio should look like. So this is your patient's total calcium, say it was 2.4. You took your ionized calcium, which was 1.2, which is nicely in the normal range. Divide that, you get a ratio of 2, less than 2.5. We're happy with that. That suggests your patient is doing really well with their citrate. However, if you take a patient's total calcium, your total calcium is probably going to be the same, so still 2.4, but you can see more of that calcium is still attached to your patient's citrate instead of being metabolized. So you've got more of your complex bound citrate, but you've got less of it swimming around in your patient. So your ionized calcium is going to be lower. So if we did our 2.4, divide that 0.8, then you'll get a number of 3, which is higher than 2.5. And that's suggesting your patient is not metabolizing your citrate. One of the strong indicators your patient is not metabolizing their citrate is that every time you do a blood gas and you write down that ionized calcium, it's kind of drifting lower and lower and lower, despite you going up on the calcium compensation on your syringe. So your prescription, if your patient ionized calcium becomes too low, your prescription will prompt you to turn up the replacement on your syringe. If you're going up and up and up on that calcium replacement, yet your patient's ionized calcium is still on the lower side, then that suggests that your patient is not metabolizing your citrate. So at that point, I would recheck my total to ionized calcium ratio as well. It's this measurement that takes units a little while to get used to and sometimes gets a bit forgotten. So we get very good at monitoring the ionized calcium of the filter, the ionized calcium of our patient, not particularly good at this one here. So it's really, really important that we make sure we do this every 6 hours, or 6 hours when they first go on, and then quite frequently after, depending on what's going on with your patient. Oh, that was quick. I thought there was some more slides on that. Has anybody got any questions? Just that, it's basically just a brief overview of what citrate does and how we monitor it on the filter. Anybody got any questions? If not, I can quickly show you the I don't know if you guys have seen your citrate prescription. Or,
I mean, anything you can show would be fantastic, Kate.
yeah, I've got it on here. Hang on a minute. So I am going in. So if anybody's around tomorrow, I am coming to Adam Brooks tomorrow just to catch up with Rachel and make sure the machines are ready and sorted to go. So I will have a catch up with him tomorrow just to check where we are with the prescription. So this prescription, currently, I think what you guys are going to use on the unit, and I'm not sharing my screen.
So the prescriptions are ready to go on Epic, are they?
Hmm?
Are the prescriptions ready to go on Epic?
Yes, I think so. So yeah, so when I went a couple of weeks ago, actually, I just need to speak with Nigel. When I went a couple of weeks ago, he said that he was going to get it up on Epic by Monday, which I think was last Monday. Should have been ready to go. But I will check. Actually, I'll email. That's a good question. I will email Nigel in a minute, see if he's around tomorrow, and I will check. But he was definitely chasing that and trying to make sure it was ready to go on Epic. Yeah, because that's been the hold up for the last, I don't know, 18 months.
Not surprised.
Yeah, apparently it takes a very long time, doesn't it, to get anything onto Epic. But the plan had been, in the meantime, if there has been a big delay getting your prescription onto Epic, please still use your Prismax machine. So you've got 2 Prismax machines that have been kindly borrowed from the adult intensive care unit. And all your nurses have training on your Prismax machine. So even if you've got a patient like tomorrow or whatever, and it's still not on Epic yet, just use them with your old heparin prescription. So people at least get used to using the Prismax machine. But I will check our email Nigel in a minute actually and see if it's on Epic yet. And hopefully it was on it, so we shall see. So this will be your citrate prescription. And I think, yeah, most of it will be on Epic, but there will be like a paper one floating around just to help you out a bit. All of the circuits, all that kind of stuff, exactly the same if you're doing citrate or heparin, so you don't have to worry about any of the different things. This is just a prescription from Nottingham that have got Oxiris there. You guys currently don't have that, so just ignore that bit for now because that probably won't be on your prescription. Always really important as well to make sure you heparin prime still. So most units for heparin prime, when they were doing heparin anticoagulation, they move over to citrate anticoagulation, and then everybody abandons your heparin prime. Our filters do really like that extra little bit of heparin just to make them a bit more biocompatible. So still heparin prime your filters. Again, this priming fluid says Plasma-Lite because that's what they use in Nottingham. However, you guys have just started using Plasma-Lite, but Nigel said he can't actually get hold of a litre bag of it at the moment. So your prescription will say saline for the time being. So your pre-blood pump fluid is going to be your Prisma Citrate 18-0. Dialysate is your Prisma Cal B22. And then your replacement is your Foxilium. This is always your first sign. And to be honest, there's not really any reason why you can't use that one. There was a query about patients that have got really high phosphate, but to be fair, the minute you put them on the filter, they're going to lose their phosphate anyway. It's only got 1.2 millimoles of phosphate in it. It's not got like a massive amount of phosphate. So I would just use Foxilium on everybody. Your calcium gluconate infusion is going to be 40 mils of calcium gluconate, 10% made up to 50 mils. And your machine knows all of that, so it knows all the calculations to give back to your patients. You can still add stuff to your bags. We just say to you not to add it to your citrate. So if you have got a patient that's got a very high sodium, say, and you don't want to drop it too quickly, you want to add it to the bag, you can do that for your dialysate in your replacement bag. Just don't add anything to your citrate bag because that's literally just citrate and some sodium and some chloride. So you can add it to your other bags, and that is all in your guideline. And again, it's going to be the same as what you did before. So the main kind of differences, and see if I can get down to them, are just going to be your flow rates. And one of the main difference on your flow rates between your heparin and your citrate is going to be how fast your blood pump is going to go. So on heparin, we probably used to run them 6 to 10 mils per kilo, and you wanted that blood flow to go as fast as possible to stop the blood clotting in your circuit. Because you've got lovely citrate there now, then as long as you've got the level correct, it is just not going to clot in your filter. So the blood flow rates are a lot slower, as you can see there. So they start at 20, then 30, and then as you get a bit bigger. So even your kind of bigger kids that are on your big ST circuit are still only going to be running at 3 mils per kilo a minute. So a lot slower than what you're used to. But that has got some benefits because it means if your VASCAP isn't particularly great, you don't have to, you know, you're not trying to achieve quite such high blood flows. So actually we found that most units move over to citrate have kind of less issues with the access. You get a lot less access alarms, a lot less troubleshooting, tends to run a bit nicer with that reduced blood flow rate there. So that's your blood flow rate. And again, your blood flow rate on heparin, you used to be able to kind of go up and down depending on what you were doing with your patient. Your blood flow rate is linked in with your citrate pre-blood pump dose. So you basically tell the machine the blood flow rate that you want. You start your citrate dose, and then it will work out the flow of that pre-blood pump for you. You don't add that in. If you change your blood flow rate, it will change the amount of the volume of citrate that's going into your machine. So it's just important that the blood flow rate you need to kind of think about before you start changing it, because it will alter the amount of citrate your patient is getting effectively. But most units, because it's a lot, we just stick it at a level and then just leave your blood flow alone once you've got it at the right place. So your citrate, just start that at 4 millimoles. Nottingham have updated, and I will have a little chat with Rachel tomorrow to see what she's done on her prescription. They've added in now like a liver impairment thing, so you can, if your patient has got known liver impairment, then you can start them at a less amount of citrate. Your dialysate is just a standard starting at 10 mils per kilo, and that's just to clear some of the citrate from your filter. Obviously, if you've got a patient that you want to do more treatment on, or if you've got a metabolic patient with high ammonia, whatever, then you can increase that to whatever you like. But just run a little bit of it just to get rid of the citrate from your machine. Your replacement is just a standard mils per hour, and it just depends on your age of your patient. And then your calcium syringe, like we said, start at 100% and then adjust it to the algorithm, which I will show you.
Consultant. Hi.
Hi. Oh, did you have a question? No. fluid removal, all that kind of stuff, exactly the same whether you're doing heparin or citrate. That's not any different. So somewhere on here you will find your algorithm. There's lots of information on here that you can read if you want. So this is your ionized, filter ionized and patient ionized algorithm, and this is what the nurses and you guys can use at the bedside to adjust your citrate dose or your calcium compensation in your filter. So this is the one that we'll do an hour after going on the filter. We take a gas from your blue port on your machine and then a gas from your patient, and depending on what the numbers are, this will tell you what you need to do. So we are aiming for the normal ideal values in the middle. So we're aiming for a filter calcium of 0.25 to 0.35, and we're aiming for a patient calcium of 1 to 1.2. You can see here, and it's got up to you guys what you want to do here, but this is just the liver impairment bit that they just recently added in from Nottingham. So if you've got a patient that's got any kind of liver issues, then you'd aim for a higher amount of calcium. So if you aim for a higher amount of calcium, then you're going to need less citrate in your filter. Basically, when you do your gases, you'll then just say your filter calcium is a little bit on the higher side, which it probably sometimes is when you first go on. Filter calcium is a bit on the higher side, but your patient's calcium is normal. If you basically just follow the boxes down till your fingers meet, then you'll get a box that tells you what to do. So if your filter calcium is too high, then what we want to do is we want to introduce more citrate into our filter to bind onto more calcium. If your filter calcium was nicely a little bit too low, which often it isn't, to be honest, but if it gets too low, then we can turn our citrate down a bit. So anything to do with your filter ionized calcium, you change your citrate dose. Anything to do with your patient's ionized calcium, if that's too high or too low, then you change your calcium compensation on the machine, and you literally just follow what it says in the box there. There is, I think, on this prescription also a really nice bit about citrate accumulation. Not quite finished yet, but it will tell you all about citrate accumulation, your initial actions. So most of it, if your filter calcium is too high, so if it's more than 2.5, then what you then do is aim for, again, a higher amount of calcium inside your filter, and then you decrease your citrate dose in 0.5 increments until you aim for a higher amount of calcium, and then repeat your ratio. And most of the time, if you just go down a bit on your citrate dose, then that will sort out your ratio. If not, there's lots of other actions to take there, and some of that just is massively dropping down your citrate. You could increase your dialysate flow just to clear more citrate from it. If your total to ionized calcium remains high despite you turning down your citrate, despite you doing all these things, then obviously at that point probably just need to stop your citrate. Either try heparin, but again, probably not going to work that much with your heparin either. You might just have to go no anticoagulation and cross your fingers that it works. And that's just all the opposite the nurse, but all that stuff will be on your Epic system. Has anybody got any questions about the prescription there?
I think it's brilliant. So essentially, it sounds like it's completely automated. We just have to write it up and then the machine does everything. Is that about right?
Yes, pretty much. Yeah. So you don't really have to do a lot. So apart from just doing your once you've done your obs, once you get your total once you get your calcium levels in the right range, you pretty much don't have to do anything else. Just keep a nice close eye on your patient's electrolytes and your gases and that kind of thing. But yeah, the machine pretty much does all the calculations stuff for you. You don't have to worry about doing any of that. So yeah,
so all the kits in the unit are ready to go, and the nurses are trained up to do it. Okay.
Yeah.
So we just
everybody is. We just need
perfect
a patient, which we don't want to wish for, but you know, we do need a patient.
Okay.
But yeah, I am popping in tomorrow. So if anybody's around tomorrow and wants to catch up, then they can. But I'm hoping to catch up with Rachel tomorrow just to check that everything is all ready to go. There are there's like Prismax hints and tips and lots of information on the machine as well. So there is lots of information there for you when you do get a patient. And the plan will be, depending on what I'm up to, when you do get a patient, you either I'll be available on the phone or I can come to the unit and just support you guys when you have your first patient on citrate. And you've got Nikki, who is the CRRT educator for Sheffield, Nottingham and Leicester. So she'll be able to help you guys if you've got any citrate issues as well. But any other questions, anything about it? Does it make sense?